We often think of our organs as these, these distinct static shapes, right? Like
Mhm.
the heart's a pump, the lungs are balloons. But when you look at the liver, I mean, really look at it the way we are going to today, it is so much more than just a wedge-shaped blob in the
Oh,
abdomen.
absolutely.
It's this massive, intricate chemical factory that's segmented, subdivided, and organized with just like military precision.
It is indeed. And calling it a blob really does it a disservice, though I totally get the impulse because from the outside, it can look a bit monolithic.
Right.
But the liver is the largest of the abdominal viscera. It is a metabolic powerhouse. And what makes it truly fascinating, and what we're going to dissect today based on Chapter 66 of the text, is its architecture.
It's architecture. I love that.
Yeah, it's designed to filter, to process, and above all, to survive.
And when we say largest, let's put some numbers on that because the scale of this thing is actually quite surprising. I was reading the source material, and the weight dynamics alone are wild.
They really are.
It changes so much depending on how old you are.
That's exactly right. In an adult, the liver accounts for approximately 2% of total body weight. So, if you weigh 75 kilograms, you're carrying around a 1.5 kilogram organ.
That's substantial.
It is. But if you go back to infancy, it's even more dominant. In a newborn, the liver is a massive 4 to 5% of their body weight.
4 to 5%. That is huge.
It is.
That's like a 20th of the entire baby is just liver. Why does a baby need that much liver power? Is it just processing all that milk?
Well, it's not just about liver power in the sense of digestion. It occupies a substantial portion of the abdominal cavity in the infant because it has a different job description in utero,
A different
a
job.
very different job. It plays a critical role in early development, specifically hematopoiesis.
Hematopoiesis? Okay, so that's making blood cells, right?
Exactly. Before the bone marrow comes fully online and takes over, the liver is the main factory churning out blood cells for the fetus.
So it's a blood factory first, and then it becomes a chemical factory later.
In a sense, yes. As the child grows, the liver grows too, of course, but the rest of the body catches up and eventually outpaces it. It sort of reaches a plateau around 18 years of age.
Okay.
And interestingly, after middle age, there's actually a gradual decrease in liver weight. It starts to shrink slightly.
Huh. It just sort of retires a little bit.
They could think of it that way, yeah.
Right, and we're going to get into those fetal connections later because they leave behind some very distinct anatomical footprints, literal ghosts of the past inside us.
They absolutely do.
But first, let's talk about what this thing actually looks like. The text describes it as having a wedge shape. Can you help us visualize that?
Correct. Imagine a wedge or a prism, a right-angle triangle almost. It occupies the right hypochondrium.
Hypochondrium. So
Yeah.
that's the medical term for the area tucked under your right ribs.
Precisely, right up under the rib cage. And it stretches across the epigastrium, which is that upper middle part of your belly, right below your sternum.
And it keeps going, doesn't it? It's not just on the right side.
It does. It doesn't stop at the midline. The tip of the left lobe frequently extends all the way over to the left mammary line, so it crosses over significantly, acting like a shield for the stomach and other structures behind it.
And the color tells a story, too. I found this part really practical. A healthy liver is reddish-brown, but the sources point out that the color is basically a diagnostic tool in itself. It's like a mood ring for your health.
It really is. I mean, if you're a surgeon and you open up an abdomen and look at a liver that has taken on a yellowish tinge or feels greasy,
Right.
yeah, you're looking at steatosis fatty liver. This is increasingly common with obesity or, excessive alcohol consumption. The fat deposition literally changes the way light reflects off the organ
It's visibly different.
immediately. And what if it goes the other way? Darker.
Right, what does that mean?
If there's a venous outflow obstruction, say the heart isn't pumping well, like in congestive heart failure, or the hepatic veins themselves are blocked in Budd-Chiari syndrome, the liver becomes bluish or deep purple. It's congested with blood that can't get out. It's like a traffic jam.
Like a bruise from the inside out?
A very good analogy.
Uh.
And then there's a texture. Usually it's soft, right?
Soft to firm, yes. It should yield to pressure. But in cirrhosis, it completely transforms.
Oh, so?
It becomes firm, hard, and nodular. It loses that smooth consistency and feels like a bag of rocks. It's unmistakable. And wrapping around all of this, the healthy and the sick, is the capsule.
Right, the fibrous capsule, Glisson's capsule.
Glisson's capsule.
It's a thin but strong fibrous layer maintaining the shape. And here is a key clinical point that I want you, the listener, to really grasp. The liver tissue itself, the actual hepatocytes, doesn't have pain receptors in the same way your skin does.
Right, really?
Really. You could cut the liver parenchyma and the liver wouldn't feel it.
So when people complain of liver pain, that dull ache in their side, what are they actually feeling?
They are feeling the capsule. Glissen's capsule is sensitive. It has nerve endings. So when the liver hypertrophies or expands rapidly, say from acute hepatitis or that heart failure we mentioned, it stretches that capsule. That stretching, that tension on the wrapper is what causes the pain.
So that dull ache isn't the cells hurting, it's the wrapper being stretched too tight, like wearing a shirt that's 2 sizes too small.
Precisely. An excellent way to put it.
Okay, let's move to the macro view. We've got this wedge, but it's not just floating in space. It has surfaces that are defined by what they touch. The text divides this into the diaphragmatic surface and the visceral surface.
Think of it as the roof and the floor. The diaphragmatic surface is the roof. It's convex, smooth, and it fits perfectly under the dome of the diaphragm.
It's molded right to it.
Exactly. It's divided into superior, anterior, right, and posterior parts, but really, they're all continuous. There's no sharp line between them. It's one smooth curve.
And there's a little dent on top, right? The text called it the cardiac impression.
Yes. Even though the diaphragm separates the liver from the heart sits so heavily there that it leaves a shallow print on the liver's dome.
Wow.
It's a testament to how packed everything is in the thorax and abdomen. There's no wasted space.
That's the roof. Now, the floor, the visceral surface, is where it gets really interesting. The source material calls this the bed of the liver. I love that image. It's like the liver is a heavy blanket settling down onto all the organs beneath it.
That is a very, very accurate visualization. Because the liver is soft, at least in a healthy state, it gets molded by the firmer organs it sits on.
So it takes their shape.
It does. If you flip a liver over and look at the underside, you can see a relief map of the abdominal cavity stamped right into it.
Let's run through those stamps or impressions because they essentially teach you abdominal anatomy just by looking at the liver. What are we seeing there?
Well, starting on the left side of this undersurface, you have the gastric impression. That's a large concave area where the stomach pushes up against the left lobe of the liver.
Okay, so stomach on the left.
Right. Then adjacent to that, near the neck of the gallbladder, you get the duodenal impression.
Duodenum. That's the very start of the small intestine.
Correct. The first part. Then, moving over to the right, you have the colic impression. This is for the hepatic flexure of the colon.
The what? The hepatic.
The hepatic flexure. It's just the bend where the ascending colon turns into the transverse colon. That corner sits right under the liver.
Ah, so the liver sits right on top of that corner.
It does, and then tucked way in the back.
What's back there?
Posteriorly, you have the renal impression for the right kidney. The liver drapes over the top of the right kidney.
So it's protecting it.
In a way, yes. And typically there's a separate, smaller suprarenal impression for the adrenal gland that sits on top of that kidney.
So if you were a surgeon and you lifted up the liver, you'd see exactly where the stomach, kidney, colon, and duodenum live just by looking at the dents they left behind.
Exactly. These relationships are so constant that they help orient the anatomy during surgery. If you see the renal impression, you know exactly where the kidney should be underneath. It's a roadmap.
Now, to keep this massive organ in place so it doesn't just slide down into the pelvis when we stand up, we have attachments, the ligaments. And there are quite a few of them.
There are. And it's important to understand that in the abdomen, when we say ligament, we usually mean a fold of peritoneum.
The lining of the abdominal cavity.
Right. It's not a tough cord like the ACL in your knee. It's more like a sheet of saran wrap holding things to the wall.
That's a great way to think about it. So let's start with the one right in the front, the falciform ligament.
The falciform ligament is the most prominent one. It attaches the liver to the anterior abdominal wall. It basically splits the superficial appearance of the liver into a right and a left section.
So that's the line we all see in diagrams.
That's the one. It consists of 2 layers of that peritoneum that are closely adherent.
And if we follow that ligament upwards towards the head.
As you go up toward the diaphragm, the 2 layers of the falciform ligament split apart. They diverge. The right layer moves to the right, and the left layer moves to the left.
Okay.
This splitting forms the coronary ligaments. These reflect onto the diaphragm, essentially creating the crown of the liver's attachment.
And this leads us to the bare area. This concept always confuses people. I know it confused me at first. What exactly is bare about it?
It's bare because it has no peritoneal covering. Remember, the peritoneum is like a sac. The liver grows into this sac, but not completely. On the posterior surface of the right lobe, there is a triangular area where the liver is attached directly to the diaphragm by loose connective tissue. There's no shiny peritoneal layer in between.
Okay, that makes sense. So it's the one spot where the liver is glued directly to the ceiling, so to speak.
That's a perfect way to put it.
Is there a downside to that, a clinical problem?
There is. Because there is no peritoneal barrier, this area is a potential route for infection to spread from the abdominal cavity right into the thoracic cavity.
Into the chest.
Yes. An abscess in the liver's bare area can erode straight through the diaphragm and into the chest.
Yikes. Okay, so outlining this bare area are the triangular ligaments.
Right. The right triangular ligament is effectively the right corner of that coronary reflection. It's usually small. The left triangular ligament is on the other side, attaching the upper surface of the left lobe to the diaphragm.
And is that one more important?
The text notes that the left triangular ligament is actually quite important for stability because the left lobe is thinner and more, mobile. It's more prone to moving.
It holds the flimsy bit in place.
Exactly. And then there's the lesser omentum. This is the L-shaped one.
It is L-shaped in its attachment, yes. It connects the liver to the stomach, that's the hepatogastric ligament, and to the duodenum, the hepatoduodenal ligament. And that one is crucial, right?
And it is absolutely crucial because the portal triad, the main plumbing of the liver, runs inside the free edge of that hepatoduodenal ligament.
Plumbing. Okay, you just mentioned it, but before we get there, we need to talk about the ghosts I mentioned earlier, the fetal remnants.
Yes. The evolutionary echoes. This is fascinating because the liver structure is literally defined by how we survived in the womb.
Let's start with the round ligament first, the ligamentum teres.
The round ligament runs in the free edge of the falciform ligament. In you and me, the adult, it's just a fibrous cord. It doesn't do much.
But in the fetus?
But in the fetus, this was the left umbilical vein. This was arguably the most important vessel in your body before you were born.
This was the lifeline from the placenta.
The lifeline, yes. It carried oxygenated, nutrient-rich blood from the placenta through the belly button directly to the liver. After birth, the cord is cut, flow stops, and the vein just collapses and scars down into a ligament.
And the source mentions something really interesting about this. It can open back up.
It can. This is a classic board exam scenario and a really dramatic clinical finding in cases of severe portal hypertension.
So high pressure in the liver's vein system.
Right, usually from something like cirrhosis. The blood is desperate to find a way out, to bypass the scarred liver. The path of least resistance might be to force that old closed vein open again.
It recanalizes.
It recanalizes. This is known as Crevillier-Baumgarten syndrome. You can sometimes even see dilated snake-like veins radiating from the patient's navel.
Whoa.
We call it Cupper Medusae, the head of Medusa, because blood is trying to get back to the abdominal wall through this reopened fetal highway.
That is wild, the body literally digging up old blueprints to survive.
It's amazing.
And then the other one is the ligamentum venosum. What was that?
Right. So in the fetus, you don't want all that precious blood from the placenta to get stuck filtering through the liver parenchyma.
Mm-hmm.
The fetus doesn't need to filter toxins yet. Mama's doing that.
Okay.
You want that good oxygenated blood to get to the heart and the brain as quickly as possible.
So you need a shortcut. A bypass.
Exactly. There is a shunt called the ductus venosus that bypasses the liver tissue and dumps blood straight into the vena cava.
And after birth?
After birth, that shunt closes and becomes the fibrous ligamentum venosum. It sits in a deep fissure between the caudate lobe and the left lobe.
So the anatomy really does act as a history book of our own development.
Precisely. It's written right into the structure.
Okay, let's get into the controversy. Or maybe evolution is a better word, the difference between lobes and segments. Historically, we looked at the liver and said, okay, there's a big right lobe and a small left lobe, divided by that falciform ligament.
The gross anatomical lobes. This was the old way, defined purely by surface features. By this definition, everything to the right of the ligament is the right lobe, which is huge. Everything to the left is the left lobe.
And what about those two little ones on the bottom?
On the underside, you have two smaller accessory lobes,
Right.
the caudate and the quadrate.
The caudate is the tail, right?
Yes. Caudates means tail-like. It's on the posterior inferior surface, tucked between the inferior vena cava, the IVC, and that ligamentum venosum we just talked about.
And the quadrate.
The quadrate lobe is more square, hence the name, and it sits between the gallbladder and the round ligament.
But this is the big aha moment in the reading for me. This surface map is wrong. Functionally, it's a lie.
It is completely misleading for a surgeon. And for understanding how the liver works, the functional anatomy of the liver is not determined by the ligaments on the surface.
Right.
It is determined by the blood vessels inside. This is the Kuno classification, named after the French surgeon who defined it.
So we switch from looking at the outside to looking at the plumbing on the inside.
Exactly. The functional division of the liver is based on the distribution of the portal vein and the hepatic arteries. If you inject dye into the left branch of the portal vein, it doesn't just light up the anatomical left lobe.
It lights up more.
It lights up the anatomical left lobe and the caudate lobe and the quadrate lobe.
Wait, so the quadrate lobe, which sits on the right side of the falciform ligament, is actually fed by the left-sided vein.
Correct. So functionally, the quadrate lobe is part of the left liver.
That's a crucial distinction. That changes everything. So where is the real divide between left and right?
It's not the falciform ligament. It's an imaginary plane called Cantley's line, or the main portal fissure.
Cantley's line.
Imagine a line running from the middle of the gallbladder bed angled back to the inferior vena cava. That plane inside the liver is the true watershed. Everything to the left is the functional left liver. Everything to the right is the functional right liver.
And that line follows a blood vessel, doesn't it?
It does. It passes right through the middle hepatic vein. The middle hepatic vein is the guardian of that border.
The guardian of the border. I like that. So Kuno broke this down into 8 segments.
8 functional segments.
And the numbering is mostly clockwise. It's a bit confusing.
It's a spiral,
Yep.
effectively. Let's start with segment I, because we need to pause on segment 1. It is completely unique. It is the independent state of the liver.
Why independent? What makes it so special?
Because unlike the other segments, which drain into the right, middle, or left hepatic veins, segment 1, which is the caudate lobe, drains directly into the vena cava through its own little short veins.
It has its own private exit.
It has its own private exit. And it receives blood from both the right and left branches of the portal vein.
So it plays both sides.
It does. This makes it functionally autonomous. If the main hepatic veins are blocked, like in that Budd-Chiari syndrome we mentioned, the caudate lobe can survive, and even hypertrophy because it has its own way out.
It's the liver's backup generator.
It's the ultimate backup generator, yes.
It is fascinating. Okay, so that's segment 1. Then we move to the left liver.
The functional left liver contains segments 2, 3, and 4. Segment 2 is the posterior lateral part way out on the left.
Okay.
Segment 3 is anterior lateral, below it. Segment 4 is the medial part. This corresponds to that quadrate lobe we talked about.
Ah, the one that functionally belongs to the left.
Exactly. And sometimes 4 is split into IVA, which is superior, and IV, which is inferior.
And then we cross Cantley's line into the right liver.
Right. Now we're the functional right liver. We go down to the bottom anteriorly for segment V, then move to the back for segment 6.
Was it in 6?
Then you go up to the top back for segment 6. And finally, the top front is segment 8. So 2, 3, 4, crossover, V's, 6, 7, 8. It's a clockwise loop around the center of the liver.
And understanding these segments is basically the holy grail for liver surgery, isn't it?
It is absolutely essential because each of these segments has its own blood supply and its own biliary drainage. They're like individual apartments in a building.
So a surgeon can remove just one apartment without wrecking the whole building.
Precisely. A surgeon can remove segment 6 and leave segment V completely intact and functioning.
Right.
This is what allows for complex liver resections and, crucially, for living donor transplants.
Ah, of course.
You can take a few segments from a healthy donor and implant them into a recipient, and they will function perfectly.
Speaking of surgery landmarks, the notes mention something called Revier's sulcus, or the fissure of Gons. What's that?
Yes. This is a cleft, a little groove, often seen on the underside of the right lobe, specifically on segment 6.
Okay, a groove. Why is it so important?
It's incredibly useful for laparoscopic cholecystectomy gallbladder removal.
Wait, why is a crack in the liver useful for removing the gallbladder?
Because it's a reliable landmark that stays open even when there's a lot of inflammation. The rule for surgeons is if you stay above the level of Revier's sulcus during your dissection, you are generally safe from injuring the common bile duct.
So it's a do not cross line.
It's a safety blinker in the anatomy, a very important one.
Let's follow the flow of blood because the liver is unique here too. You mentioned the plumbing. It has 2 inflows.
The vascular highway, yes.
Yeah.
Most organs have one artery bringing blood in and one vein taking it out. The liver is greedy. It has the hepatic artery and the portal vein.
Both bringing blood in.
Both bringing blood in. And they enter at the porta hepatis.
The gateway to the liver.
The gateway. The porta hepatis is a transverse fissure on the underside. It contains the portal triad, the portal vein, the hepatic artery, and the bile duct.
And their arrangement is really specific, right?
It is. The arrangement is classic and vital for surgeons to know. The bile duct is usually anterior and to the right. The artery is anterior and to the left. And the big portal vein is posterior, sitting behind them both.
DAV.
DAV. duct, artery, vein, from right to left and front to back.
Let's break down the two inflows. First, the hepatic artery.
This is your standard arterial supply. Comes from the celiac trunk. It brings oxygen-rich blood. But surprisingly, it only accounts for about 25% of the blood flowing into the liver.
Only a quarter. That seems low for such a big organ. So where is the rest coming from?
The portal vein. It provides a massive 75% of the liver's blood flow.
75%.
Yes. And this is venous blood. It's coming from the stomach, intestine, spleen, and pancreas. It is poor in oxygen, but incredibly rich in nutrients that were just absorbed from your last meal.
This highlights the liver's job perfectly. It's not just keeping itself alive with oxygen. Its main job is processing everything we eat.
Exactly. The liver is the first stop for anything entering the blood from the gut. It filters toxins, processes glucose, and manages lipids before that blood goes to the rest of the body.
It's the gatekeeper between digestion and circulation.
The ultimate gatekeeper.
Now, the source material detailed some important variations in the arteries. Apparently, the textbook anatomy only happens in, 50 to 60% of people?
Roughly. Maybe a little more, but variations are very, very common. About 20% of people have a replaced or accessory hepatic artery.
What does that mean, replaced? Did it get lost?
Not quite. It just means instead of coming from the usual spot, the celiac trunk, a hepatic artery might branch off the superior mesenteric artery, the SMA, or the left gastric artery.
And that matters because
A replaced right hepatic artery coming from the SMA is a classic trap for an unsuspecting surgeon.
a trap.
Yes. If a surgeon is operating on the pancreas or the gut, and they don't realize that the main blood supply to the right liver is traveling through a different path right through their surgical field, they could accidentally cut it.
And what happens then?
That causes necrosis of the right liver. The tissue dies. It's a catastrophe.
So it's high stakes.
Very high stakes. Identifying these vascular anomalies with imaging before surgery is a critical part of preoperative planning. You have to know the map before you drive.
We've got blood coming in. How does it get out? The drainage system.
We touched on this with the segments. The blood flows through the liver tissue, gets processed, and then it collects into the hepatic veins.
The three musketeers, the text called them.
Right, there are three main ones. The right hepatic vein, draining the right lateral segments, V, 6, and 7. The middle hepatic vein, draining the central segments, the 4, V, and 8. And the left hepatic vein, draining the left side, 2 and 3.
And they all dump into the IVC.
Yes. They converge at the very top of the liver and empty directly into the inferior vena cava just before it passes through the diaphragm to the heart.
What about lymph? We don't talk about lymph enough in anatomy, but the liver produces a lot of it.
A massive amount. The liver is a major producer of lymph, and it's very protein-rich. There are two systems: the superficial lymphatics in the capsule and the deep lymphatics that follow the portal triads inward.
And where does it all go?
Mostly it flows down to nodes at the porta hepatis and then the celiac nodes. But, and this is interesting, some lymphatics from the bare area track upwards.
Through the diaphragm.
Right through the diaphragm to nodes in the chest, in the mediastinum.
Why does that matter?
Because it can be a route for the spread of disease. It means liver cancer or an infection can track directly into the chest, bypassing the abdominal lymph nodes entirely.
It connects the abdomen to the thorax again. It's another one of those back doors.
Another back door, exactly.
Now, I want to touch on nerves quickly. We mentioned the capsule pain earlier, but the source connects this to shoulder pain. Why on earth does a liver problem hurt in your shoulder?
It's a classic phenomenon called referred pain.
A referred pain, okay.
The diaphragm and the liver capsule are supplied partly by the phrenic nerve, and the phrenic nerve originates from nerve roots C3, C4, and C5 in your neck.
C3, 4, 5, keep the diaphragm alive. The old mnemonic.
That's the one, exactly. But those same nerve roots, C3, C4, C5, also supply sensation to the skin of your shoulder via the supraclavicular nerves.
Ah, so it's a shared pathway.
It's a shared pathway. So the brain gets a pain signal from the C3, C5 level. It's confused.
Yeah.
It doesn't know if it's from the diaphragm or the shoulder. It just assumes the pain is coming from the skin of the shoulder, which it hears from more often, even though the irritation is actually at the liver or diaphragm.
That is always such a mind-bending concept, your brain getting its wires crossed.
It is. It's a neurological quirk with major diagnostic importance.
Okay, we have dissected the gross anatomy. We've looked at the plumbing. Now, I want to zoom in, way in, to the microstructure, the hidden cities of the liver.
This is where the real work happens. The microscopic architecture of the liver is It's just beautiful and incredibly complex.
We have 3 different ways of defining the basic unit of the liver: the classic lobule, the portal lobule, and the acinus. Why 3? Why not just 1?
Because they describe different functions. It depends on what process you're interested in. It's like looking at a city map. Are you interested in the roads, the water pipes, or the power grid?
Great analogy.
Let's start with the classic lobule.
Yeah.
This is the one you see in most older textbooks. It's hexagonal, six-sided. In the very center is a central vein.
Okay.
And at the 6 corners of the hexagon are the portal triads.
So blood flows from the corners, the triads, inward to the center vein.
Correct. This model emphasizes the endocrine function and, most importantly, the drainage of blood. It's visually the most distinct pattern under a microscope.
But then there's the portal lobule.
The portal lobule flips the script. It puts the portal triad in the center.
The opposite.
The exact opposite. Imagine a triangle connecting 3 central veins with a portal triad in the middle. This model emphasizes the exocrine function, specifically bile secretion,
How so?
because bile flows in the opposite direction of blood. It flows from the cells towards the triad in the center to get to the bile duct.
Okay, that makes sense. Blood in, bile out. But the source says the most functionally useful model, especially for doctors, is the liver acinus.
Yes, the acinus is the true functional unit. It's diamond-shaped. It spans the territory between 2 central veins and 2 portal triads.
Right.
But the genius of the acinus model is that it breaks the tissue down into zones based on blood supply.
Zones 1, 2, and 3. Let's walk through these because they react very, very differently to injury.
Very differently. Zone 1 is the periportal zone. It's closest to the incoming blood supply from the portal triad.
So it gets first dibs on everything.
First dibs on oxygen, first dibs on nutrients. These cells are the best fed.
So they are the elite, the healthiest.
In a way, yes. They are the synthesis engines. They perform tasks that require a lot of energy, like making proteins. And because they are well fed, they are the first to regenerate if the liver is damaged. They lead the charge in healing.
Then zone 2 is intermediate. And zone 3, what's its story?
Zone 3 is the pericentral zone, right near the draining central vein. By the time blood reaches zone 3, the cells in zones 1 and 2 have already taken a lot of the oxygen and nutrients out of it.
So they get the leftovers.
They get the leftovers. So zone 3 is relatively hypoxic. It exists in a state of low oxygen tension, even in a healthy person. It's living on the edge.
Exactly. And because they are oxygen poor, zone 3 cells are the most susceptible to ischemic damage. Ischemic meaning lack of blood flow.
Right. If your blood pressure drops during shock or you have severe heart failure, zone 3 dies first. This leads to what we call central lobular necrosis.
But they have a superpower too, right? It's not all bad for them.
They do.
Yeah.
It's a double-edged sword. Zone 3 is where a lot of drug metabolism happens. The cytochrome P450 enzymes are highly concentrated here.
So they're the detox crew.
They are the detox crew. But in cases of toxic injury, like an acetaminophen, a Tylenol overdose, the toxic metabolite is produced right there in zone 3. So zone 3 often takes the hit for toxins as well as for low oxygen.
So the location of the damage under a microscope tells the pathologist what caused the injury. That is incredible detective work.
It is. It allows us to reconstruct the crime scene just by looking at which zone is affected.
Let's meet the cast of characters living in these zones. First, the hepatocytes.
The stars of the show, the main workers. These are large polyhedral cells with anywhere from 5 to 12 sides. They make up about 80% of the liver's volume.
And they're just packed with machinery.
Packed. They're loaded with mitochondria for energy, Golgi apparatus for packaging proteins. They're constantly working. They can even have 2 nuclei sometimes. They're that active.
And they are arranged in plates, right? Like walls.
Cords or plates of cells, usually 1 cell thick. And running between these plates of hepatocytes are the sinusoids.
The sinusoids. These aren't normal capillaries.
No, they are highly specialized. Normal capillaries have a continuous lining to keep things in. Liver sinusoids are lined by endothelial cells that are full of fenestrae,
Fenestrae meaning windows.
literally windows or pores. And they lack a continuous basement membrane underneath. They're leaky by design.
Why do they need windows? What's the point of being leaky?
To allow blood plasma to flow freely out of the vessel and wash directly over the surface of the hepatocytes. This exchange happens in a tiny space called the space of Dissy.
The space of Dissy. It sounds like a location from a sci-fi novel.
It kind of is. It's the perisinusoidal space. It's the tiny gap located between the leaky endothelial cells and the hepatocytes. This is where the real chemical exchange actually occurs.
And the hepatocytes reach out into it.
Yes, the hepatocyte surface is covered in microvilli that extend into this space to massively increase the surface area for absorption and secretion.
And hanging out in this area are some other cell types, the Kupffer cells.
The security guards. Kupffer cells are actually specialized macrophages. They're immune cells that sit inside the sinusoids.
Inside the blood vessel itself.
Right in it. They anchor themselves to the walls like spiders in a web. Their job is to catch and eat bacteria, old red blood cells, and any other debris flowing through the blood from the gut. They are the liver's frontline filtration system.
And finally, the stellate cells, or Ito cells. These guys seem to have a dual personality.
Oh, they are the absolute Dr. Jekyll and Mr. Hyde of the liver.
Okay, tell me about that.
In a healthy liver, hepatic stellate cells sit quietly in the space of Disse, and their main job is to store vitamin A. They're full of lipid droplets. They are dormant, peaceful.
But when things go wrong, when the liver gets injured.
When the liver is chronically injured, say by alcohol or hepatitis C, these cells get activated. They undergo this dramatic transformation. They lose their vitamin A droplets, they turn into myofibroblasts, and they start pumping out collagen.
And collagen is scar tissue.
It's scar tissue. They start laying down scar tissue in the space of Disse. This blocks the fenestrae. It clogs up the whole system. It turns the open, porous sinusoids into stiff, narrow tubes.
So that's fibrosis.
That is the fundamental mechanism of fibrosis and cirrhosis. The very cell that was meant to store a vital nutrient ends up strangling the liver with scar tissue when it gets angry.
It's a protective mechanism that has just gone terribly wrong.
Precisely. And briefly, the sources also mention pit cells, which are natural killer cells specific to the liver, adding yet another layer of immune defense.
It really is a fortress. We've gone from the massive lobes, the size of a football, down to the individual immune cells guarding the microscopic alleyways of the sinusoids.
It's a remarkable journey of scale, isn't it?
So if we step back, what does this all mean for the listener? We've covered a lot of anatomy. What's the big takeaway?
I think the main takeaway is that form follows function perfectly. The liver isn't just a simple filter. It's a segmented, resilient, dual-supplied organ designed to withstand an incredible amount of stress.
It's built for abuse.
It is. It can regenerate, thanks to those cells in zone 1. It has a backup drainage system in the caudate lobe. It filters our blood before it ever reaches the heart or the brain.
It's the gatekeeper.
It is. And understanding this anatomy, the segments, the blood supply, the zones, isn't just for surgeons. It helps us understand how diseases like cirrhosis or cancer spread. And it explains why the liver can take such a beating and keep us alive.
Absolutely. And here's a final thought to chew on for everyone listening. We talked about zone 1 being the survivor and zone 3 being the vulnerable one. It really makes you think about the liver's constant balancing act at a microscopic level between abundance and starvation happening with every single heartbeat.
And I'd add this. Think about segment I, the caudate lobe. It's physically tucked away deep in the back, protecting its own blood supply and its own private drainage. It's the ultimate survivalist bunker within your own body.
A survivalist bunker. I love that.
So next time you see a medical diagram of the liver, look for that little tail. That's the part of you that is designed to survive, even when the rest of the system starts to fail.
That is a fantastic thought to end on. Thanks for taking this deep dive with us.
My pleasure. It was great.
And thank you for listening. We'll catch you on the next one.